From the classroom to the emergency room, OR and beyond, you're joining Trauma ICU Rounds with your host, Dr. Dennis Kim.
Welcome back to Trauma ICU Rounds. I'm your host, Dr. Dennis Kim. Today, I am very excited to be speaking with Dr. Clay Cothran Burlew, who is a trauma and acute care surgeon at Denver Health. Dr. Burlew wears many hats. She is a professor of surgery and the director of the Surgical Intensive Care Unit, as well as the program director of the Surgical Critical Care Fellowship and the double AST-approved Trauma and Acute Care Surgery Fellowship. Dr. Burlew is an active and busy surgical investigator, educator, and clinician. She's received multiple awards for academic teaching and mentoring excellence. She serves on the Committee on Trauma for the American College of Surgeons and the Board of Managers for the American Association for the Surgery of Trauma. Dr. Burlew also serves on all of our key national committees, including the Western Trauma Association, and she's a past president of the Southwestern Surgical Congress. Dr. Burlew has authored over 170 peer-reviewed articles and 70 book chapters. In addition, she's given over 100 national lectures and scientific presentations. Among her many clinical and research interests are the evaluation and management of blunt cerebral vascular injuries, as well as the management of unstable pelvic ring fractures, which is the topic of today's rounds. So recently on Twitter, I had tweeted out a case of a severe hemodynamically unstable pelvic fracture and wanted to get a sense from Twitterverse, trauma surgeons, fellows, and residents as to how they might manage this particular clinical scenario. Now, you and your group at Denver Health have been writing about this topic for quite a while now, and whether it's the development or evolution of your multidisciplinary pathway for unstable pelvic ring fractures or the increased application of preperitoneal packing, I'd love to get your thoughts on the optimal approach to the management of patients with hemodynamically unstable pelvic fractures.
Yeah, so, I think it has been a process and an evolution. I think you tag it very nicely. And we have been trying to refine our management of pelvic fracture patients, particularly those critically ill and injured ones, for the last probably 3 decades. So we started just by introducing algorithms. We adopted hemostatic resuscitation, and we still had patients, despite algorithms and appropriate resuscitation and angiography, who were still dying either pretty quickly after admission or even in the angiography suite. And that's a bad feeling, as you can imagine. And so back now almost, I want to say 17 or 18 years ago, we started adopting the European sort of approach or mentality about packing the pelvis, recognizing that so many of these patients have venous and bony fracture-related bleeding that's causing the problem and not so much the arterial side. And so I think that, our trigger point for intervention in patients is exactly the same, whether it's for angiography or for fracture-related or pelvic packing. So our intervention has changed. We switched from angiography as the primary intervention to pelvic packing, but that trigger point being hemodynamic instability despite 2 units of blood is still the same trigger point. So our algorithm is exactly the same except the type of intervention. And so we've done packing since then. And for us, at least, we really think that external fixation combined with pelvic packing in those critically ill patients is producing the best outcomes. And so that's why we've adopted it. We've tried to critically review our results with it, and we continue to do it.
So was that initial change in management driven by delays in time to definitive management or angioembolization, a shift in philosophy based on clinical success from centers in Germany and Europe, or some combination of the above?
It's a little of both. It takes only that one patient, literally, where I'm standing in angio and they don't make it out of angio. We, as a level 1 trauma center, we have angiography that's within designated times. They were prompt in their response, so we have as good of an angio capability, short of, them being at my elbow every moment, as any other level 1 trauma center. And I think as we recognize, this is a very small percentage of patients. This is only 6 to 8% of all pelvic fracture patients that we're talking about. So it's just that very small subset that are so critically ill and have massive hemorrhage into their pelvic space and retroperitoneal space. And angiography, even if it's that extra 30, 45 minutes, an hour, it's also not combating the main source of hemorrhage. So So it wasn't that it was a lack of angiography. And we actually proved that when we first adopted pelvic packing, we would take patients to the OR for pelvic packing and then take them directly to angiography. We still, in those patients, made it to angio faster than if we had just called angio the minute the patient hit the door. So to us, it wasn't an issue of, oh, we don't have angio until hour 5, for example.
Right.
It really is that at 30 minutes or 45 minutes, that patient needs to have packs in place.
Oh, that's great. And there was a paper a few years ago out of Shock Trauma where they actually showed that time to definitive angioembolization was on the order of 4 or 5 hours. Yeah.
And that's exactly why I mentioned that. I think, and Shock Trauma is one of the premier level 1 trauma centers, and they actually often have on-site angiography. Physically present angiographers.
Yeah.
So if it takes that long for shock, and there's another report out of Houston, there's been other reports since then, we all think that it's a shorter time, and it may not be. And again, I would sort of argue maybe angiography isn't the right first step. Yes, it helps diminish inflow, which I think is part of it, but we recognize that only 15% of pelvic fracture related bleeding is arterial in nature.
Right.
So again, I would rather aim for the 85% of bleeding, which is venous and bony in origin, and address that source primarily. And then in the 15% of patients that have concurrent arterial bleeding, absolutely, I want my angiographers to be part. So this is not an either or situation. It is a complementary which patients need angiography after they've had pelvic packing.
Now, you mentioned the 2 units going in and then patients still being unstable and that kind of being the trigger. Obviously, the majority of these patients, if they're unstable, are going to have a T-pod or a pelvic binder placed. Sometimes we've heard from our orthopedic colleagues and they've kind of looked at the fracture pattern and, oh, that's an LC2 or 3. And why on earth would you bind that? Save that for those bad APC fractures where you've got a bad diastasis and a truly open book pelvic fracture. But are we getting a little too smart for our own good? If you got a patient with an unstable pelvic fracture, you're transfusing your blood and they're there, are you not going to just bind them?
Yeah, I think you bring up a great point, and everyone always tries to put that asterisk on pelvic binding. I maybe have a little bit of a different take on it. We do pelvic sheets, so just very simple sheets across the greater trochs. Anchor it on either side with a penetrating towel clamp. And what I try to remind my residents is it's less about, for some, it's about closing the pelvic volume. If you really have a wide diastasis, it is about trying to close down that pelvic volume a little bit, because then your resuscitation of the pelvic space is smaller. If you think of a tank, the bigger the tank is, the more blood you have to put in hopes that it'll tamponade. Yeah. So if you close down that tank a little bit, then you put less blood into the tank to try and fill it. However, if you also think that some of the problem with bleeding is the shifty of the bony elements and the disruption of the veins in the pelvic space, then to me, a pelvic sheet is, for some, about closing the pelvic volume, but it's also about preventing ongoing movement of the pelvis in general. So I really, when we do the pelvic sheet, I try to have my team gently press in on the pelvis to just sort of hold it in one place. And then we anchor the sheet across the front of the pelvis so that it's just stabilizing the pelvis. And it's not a big torque or a ratcheting down of a pelvic binder or a twisting of the sheet around the top of the pelvic brim. It's really just about stabilizing that pelvis so that it doesn't continue to shift and cause further damage.
Now, REBOA, this is something that, for the last decade or so.
Oh, you picked a hot topic.
Where are we in terms of use of REBOA? I think when it comes to these hemodynamically unstable pelvic fractures, a lot of folks are arguing that this is really that one good indication for maybe a zone 3 deployment, provided that there's no evidence of free fluid or you're not concerned for intra-abdominal injury.
So you've tipped my hand, and maybe it's the perfect starting point. We actually, for the upcoming AAST meeting, have our internal review of our use of REBOA in pelvic fracture patients. So I won't show my hand too much so that you'll wait for that presentation. But no, I think the data to date is very mixed about what the role of REBOA is. And I think that we've seen it's very polarizing. Some people are very pro-REBOA and some people are very anti-REBOA. And people seem really staunch in that. As I sort of ask people or look around, really, for some, there's not much gray zone. For me, I think that there is a little bit of a gray zone, and there are definitely times that I think a REBOA has saved a patient's life. I can tell you standing in the trauma bay with a systolic of 50 and someone who is basically, vertically sheared their pelvis on and has a huge open perineal wound that they're bleeding out of. That pressure of 50, I got up to 90 with a REBOA, which is just an aortic cross clamp. It's a fancy aortic cross clamp. And so whether I had opened the abdomen and put the cross clamp on or opened the chest and put the cross clamp in, it still is a fancy cross clamp. And for that patient, I think the key was then we put the REBOA up, the systolic pressure came to 90. We perfused the heart and the brain and all the important stuff. And we immediately took him and had his pelvis packed and resuscitated him. And then we had the REBOA, and from start to finish, it was an hour. He hit the door, REBOA in, upstairs, pelvic packing, X-fix, REBOA out, all within an hour. And so I think there are going to be situations where, for me, I've seen that it happens real time. Is that going to be reflected in every database? Maybe not. And I think that part of the key is incorporating REBOA within a very clearly defined algorithm and in the patient population that is quite marginal. And so personally, I think there is a role for REBOA. Do we put it in every patient? Absolutely not. And again, it's a fancy aortic cross clamp, and it does increase the systolic pressure. Even if you have intra-abdominal hemorrhage, it'll still increase it, maybe bleed a little more, but it'll still increase that intra-abdominal or the overall systolic blood pressure. So I think it's like any other technology. It's the same as I say about pelvic packing. If you use it appropriately and you have specific indications and you know what the risk and benefit is, for me, it has a role just like any other tool in my toolbox. I don't use it as often. I use it even less in that. So you've already taken all pelvic fracture patients. Then you go down to 6 to 8% that are going to be those that fall into the pelvic packing X-fix paradigm. And then you shave that maybe in another half or third that are those that have a systolic pressure of 60 or 65 who are basically about to arrest. And those patients, you maintain that blood pressure and you get them upstairs and you pack them. And it's a bridge, and that's what it is.
Yeah, no, absolutely. It's a good adjunct. And again, the specific patient population that's going to benefit is so hard to define. But we also have the same experience where, we get that sheath in on the unaffected side, ideally. And then, you've got access for angioembolization, you've got the balloon in, you temporize, get them upstairs. And at your place, so are you going just to the regular OR to do your preperitoneal packing, or is it more of a hybrid type of a suite?
Yeah. So if we wanted to do, for example, say we put a REBOA in and we took the patient up to it's just a regular OR, we still have a fancy C-arm that could come in and we could do a flush angiogram of the pelvis if we wanted to, as we deflate that balloon, or if we wanted to put catheters up. We can do that even though it's not a classic hybrid operating room per se. And we recognize that hybrid operating rooms, maybe you really need a fancy C-arm is what you need, right? And someone who has catheter skills. But again, the number of patients that have arterial sources of hemorrhage that need embolization, in our experience, is about 13% of patients. And the great thing about that is once you pack them, typically patients stabilize. And so you don't need to do that additional angiography for, on average, up to 8 to 10 hours. So you really can resuscitate the patient, address their other injuries, do other procedures, take care of the general. And then if they still have some ongoing bleeding once you fix their coagulopathy, then you can take that patient and do formal angioembolization. But no, if we can also do a flush angiogram. The question is what's the utility of that in the 12% of patients or 13% of patients that have an arterial source. So regular OR works just fine.
Yeah, absolutely. Completely agree. And just trying to navigate the hybrid OR is a task and a skill in and of itself.
I can well imagine. But again, if people feel more comfortable, I think some of the reluctance to adopt packing is, number one, historic, right? We have been taught, don't touch the pelvic hematoma. Whatever you do, don't touch the pelvic hematoma. And now I'm telling you, I want you to jump right in there. I want you to open up the pellet, but I want you to do it through this very small suprapubic incision in a controlled space and keep it separate from the abdominal space. Because if you decompress that pelvic hematoma into the abdomen, then the game is probably over, actually. So I think it's some of that, but I think if going to a hybrid room, and again, external fixation, packing into a fixated pelvis is part of the critical point of this. So you have to have buy-in from your orthopods. I think that's what has made our success so much better in Denver, maybe than elsewhere, based upon partners that have joined us that say, oh, it's the external fixation. That's the key point. We packed pelvises, but it didn't make a difference. So I think clear trigger point, external fixation, packing the pelvis. But if people want to try packing the pelvis, but they want to be in a hybrid room so they can immediately angio the patient, I think that's a great way to adopt a new technique that maybe you are a little bit uncomfortable with. So that's what we did. We aligned the paradigms so that we felt comfortable we were safely doing
That's great.
it.
Having that multidisciplinary buy-in, I think, is so critical for so much of what we do, both in the ICU as well as in the trauma
Totally.
bay.
Totally
Now,
agree.
let's say we have a patient who's hemodynamically unstable after a blunt MVC or a blunt motorcycle crash. They've got a positive FAST. They've also got a horrific APC3. You bind them, you give them your 2 units of whole blood and the TXA potentially, and they're still unstable. So we want to maintain separation of our incision. So how
Yeah.
would you approach that in terms of your choice of incision? And would you just go to something like hypogastric artery ligation or still attempt
Oh,
preperitoneal
hypogastric.
packing?
Oh, now I feel old school. That is awesome. So no, it's a great question, and it is the clinical scenario that we are met with not infrequently in these
Yeah.
patients. So I think the first thing, and this is that clinical acumen, you have to gestalt which is the bigger source of hemorrhage. So do you go in the abdomen first, or do you pack the pelvis first and
Right.
exfix the pelvis? Now, I will say to some degree, I talk a lot about, and the multidisciplinary aspect that you brought up is really critical. Our orthopods can pack the pelvis just as easily as we can. So if I'm in the chest doing a thoracotomy for something, or I'm in the abdomen, they can X-fix and pack the pelvis while I'm working up in the chest or abdomen. Now, working with the drills and the tinker toys, it only takes them 3 to 5 minutes to put that on, but they've got big stuff that's near me. So sometimes we battle a little bit for territory if I'm in the abdomen. So I think if you can separate it and say, okay, I'm going to address I have a binder on, or a sheet. For us, it's a sheet. I'm going to have my orthopods in there. They're going to be totally ready to go, but I'm going to go ahead and open the abdomen and take out the spleen, pack the liver, staple out the, mesentery, or, use my ligature, whatever. I'm going to control the major sources of bleeding in the abdomen, which typically you can address within 10 to 15 minutes. You can get the spleen out, pack the liver, make sure there's not a big rent. But then the key is you're going to see all that blood up that retroperitoneum. So you don't want to open up the retroperitoneum unless you clearly have a big, renal hematoma that's expanding that you think that they've avulsed a kidney or something.
Right.
So you ignore all that blood that's tracking up from the pelvic space. And you can even look down in the pelvic space. Sometimes we go to the OR and they've got a pelvic fracture, and we take the spleen out and we pack the liver, and then we look down and they actually don't have a big pelvic hematoma.
Right.
So sometimes just reassessing at that point, once you're in the abdomen, they don't have something down there that I'm worried about, and they've stabilized now, the spleen is out or the liver's packed, and I've controlled the hemorrhage. Maybe we're okay.
Right.
Maybe we just X-fix them. Alternatively, you address the abdominal source. They're still unstable. You look down, they have a big pelvic hematoma. You have your orthopods externally fixate the pelvis, make sure they put that bar down low so it's not in your way. And then through your separate incision, you pack the pelvis. And so I agree with you. Your laparotomy, really you try to stay above the umbilicus, because if you go below the umbilicus and open up that pelvic space, then you're going to find yourself in a little bit of trouble. So just separate your incisions, and you literally have one little tiny 6 to 8 centimeter incision above your pubis, and then your regular upper midline laparotomy for whatever's going on with your solid organs.
And then getting back to the hypogastric ligation, if you do a big old standard X-lap, and then you happen to find an expanding zone 3 hematoma, or it's kind of obvious that they continue to bleed from that pelvis, any thoughts or considerations for hypogastric artery ligation?
So, and I say back in the old days, before we, 20 to 30 years ago, we would send slurry down that internal iliac. We would, put clips on that hypogastric or put a big old silk around it.
Right.
To me, I don't think that, in my experience in the last 20 years with packing, you don't need to do it. So you address whatever's in the abdomen, you see the pelvic hematoma, and you're like, whoa, that's bad. Pack the X-fix, pack the pelvis, and then just pause. And to me, to go down and ligate that hypogastric, you are opening that pelvic hematoma, that pelvic space, and they're going to then decompress into the abdomen.
Right.
So, and also, again, you're talking about, that would be like doing a empiric bilateral internal iliac embolization.
Embolization, yeah.
And when we go to embolize these patients again, then you're also picking out only, again, only about 10 to 15% of patients have arterial bleeding. And of those, do they really have significant bleeding on both sides that requires a hypogastric embolization? The odds of that are, again, I could go back through my exact embolizations. I don't think anyone
Right.
really needed both hypogastrics taken out. And so you've jumped to this radical therapy versus, okay, let's temporize, pack them and temporize them, resuscitate them, fix their coagulopathy, fix their acidosis and their hypothermia, and then let it settle out. And that's that period. Packing buys you that time to let them settle out and figure out what you need to embolize. Because if you haven't had a perineal necrosis from bilateral internal iliacs being embolized, then you haven't seen one of the worst complications of embolization. And I've seen it even in the last 10 years on a patient that was empirically embolized, and they necrosed their anus. And it's one of the most impressive things and I've seen it more than once in the last 25 years. So it's not without risk. Maybe it's just one a decade, but I don't even want the one a decade. So that's why, it sounds great. It sounds heroic. It sounds like something a trauma surgeon should do, but I just don't think we need to hit that hammer.
Now, one of the things that's come up at our shop is when we're sticking, these 3 lap pads on either side of the extraperitoneal space, and patients have potentially even with the open or closed pelvic fractures, does the risk of infection go up when we do that? We leave these packs in there for maybe a day or two, and later our orthopods want to come back and perform definitive fixation. Having those lap pads there, does that increase the risk?
Yeah, it's a great question and something that we worried about early on. So I think one of the critical things that we've tried to do is to review our own experience. And so at our first review, about 5 to 6 years in, we noticed that in those patients that not just with one packing, but say we went back to unpack them and we pulled the packs out and there was still some oozing and still a little bit of bleeding, if we repacked those patients, then the infection rate went up markedly. It went up to almost 50% of patients would get a pelvic space infection.
Oh, wow.
So the great thing, again, we learned, yes, they were alive to get the infection, which I guess you could argue that's a plus.
Pretty good outcome.
We don't want them to have the infectious morbidity. Absolutely. So we recognize that we really push to only pack once. So when you take them to unpack, you want to make sure that the orthopods aren't going by themselves, because sometimes they'll just go, oh, there's some bleeding in there, let's just repack them.
Right.
You really take a good look. There's usually a little tiny vein that needs a clip, or sometimes there's a bigger venous injury, or there's some avulsion or stuff along the top part of the bladder that just needs a couple of vicral sutures put in. And really looking in that pelvic space, putting hemostatic agents in there, some flow seal or some other stuff in there to help that space. And then your infectious rate, the infectious morbidity drops to about 5 to 7%. Would I wish that it was 0%? Absolutely. In general, even in those patients, many of them have open fractures, which we recognize that the infectious morbidity goes up in those. And even in modern series, the mortality rate of open fractures, non-pelvic packing open fractures, is over 40%. So again, I'm talking about a mortality rate closer to 14% with some infectious morbidity there. So again, I think it's a little bit of a trade-off. But then additionally, the real question is, should the orthopods go in that space and put plates on? And so we've looked at that, and we don't feel, there are occasions, I can think of 3 patients in the last 18 years that have had to have revision surgery for their hardware. Most of them were early in that process with the repacking. And so our orthopods actually are comfortable going back into that pelvic space after there have been packs in place. So again, I think it's something we continuously evaluate as we try to improve our outcomes on every metric related to this. But we haven't felt that the infectious morbidity is prohibitive in these patients.
Yeah. There was, I think it was a double AST master surgeon talk, but there was a talk you gave on, these sort of hemodynamically unstable pelvic fractures. And there was an interesting slide when we talked about open pelvic fractures. Are you using some sort of antibiotic slurry or powder, or routinely laying that down still? I think it was like a rifampin, Vanco combo.
Yeah. So it's sort of true and maybe unrelated. So part of the slide was, I love it when you read in a textbook, you have to remember any textbook chapter is one person's opinion with a little bit of data. And so one of the things that cracked me up was it says in the trauma textbook, open pelvic fractures pelvic packing doesn't work. And so I read that and I was like, wow, there's no reference, there's no data point. So we actually looked at our open pelvic fractures, and it turns out they get a little more blood, which is not surprising, but pelvic packing does work in those patients. And so that's one component of it. The infectious morbidity in those patients maybe is slightly higher, as I mentioned. And so I think we do give perioperative antibiotics and try and make sure that we limit, just making sure that we have good tissue debridement and making sure that we do all the normal stuff that we would do for an open fracture. The slurry that you're talking about is, and I always have to recall, rifampin was part of it, and maybe it's or something else, but it's a slurry that in 2 patients, when we repacked them, so I had the data of, I knew that there's a 50% infectious morbidity in patients that get repacked. So I had a day where an orthopod called me and said, hey, Clay, you're going to be so psyched. I took that patient back. I took the packs out, but they were bleeding. So I just put them back in and I put them on the schedule for you for tomorrow. You don't mind taking them back out. And I was like, wait a minute, we've talked about this. This patient has a 50% chance of having a pelvic space infection. So what I did is I extrapolated, because that's all surgery is. It's great. You have to think on your feet. You have to extrapolate from other situations.
Absolutely.
I went to my vascular colleagues. I said, hey, I know you have this weird slurry you put on infected grafts to try and minimize local infectious morbidity. Talk to me about the slurry, because I think I want to put it in the pelvic space when I take this patient back tomorrow to take these packs out for the 3rd time. And so that's the slurry. So we've done that. So I've had 2 patients that my well-meaning orthopods thought they were doing me a favor by not calling me and interrupting my day, and they just repacked them and put them back on. So in those 2 patients, I did the slurry into the pelvic space, and neither of them got a pelvic space infection. So you can either say that they happened to, luck out, or one of them technically should have gotten it and the slurry helped them.
Right. Cool. Well, I'll find that slide and take a little screenshot and post it to the website when we put out this episode.
So yes. So the better thing is not to repack the pelvis.
Right. That's the
better way to go about it. But
Absolutely.
If you do, you might think about using the slurry. Maybe that's a way to think about it.
I like it. Now, I know we're short on time, Dr. Burlew, but one last thing. Obviously, you guys have been leaders in terms of the use of TEG and thromboelastography, as well as pre-hospital plasma resuscitation. Have you noticed a change in terms of survival by using things like thromboelastography in the OR? So if you've got a patient with a hemodynamically unstable pelvic fracture, you've gone upstairs to do your preperitoneal packing and X-Fix, how often are you ordering the TEG? And has that really changed outcomes?
So we had hemostatic resuscitation before we started pelvic pack. We were doing that back in the 90s and 2000s. And so we already had sort of an empiric ratio approach, which is what I tend to think of with hemostatic resuscitation. And so this was, again, another pelvic packing and then REBOA were adjuncts to that original algorithm. We obviously are advocates for TEG-based resuscitation. And I think that we have incorporated that as our overall management. And we recognize that we base our resuscitation based upon what the TEG indicates the patient needs in a very real way. And when you look at our outcomes, I'm not sure that the outcomes are TEG-based, because our ratios are still the same that they've always been, meaning that they all still get 1-2 resuscitation with product in that initial, both within the time of packing and then within the first 24 hours. So what we really see is that the packing halts the bleeding and the need for resuscitation. And then I think that what happens is, as we TEG this, so they get packed within, the first 1 or 2 hours of admit, halts the bleeding. The number of transfusions after packing statistically drops significantly. And then I think our TEG that we're getting, that second TEG, we get one in the ED, that second TEG or third TEG that we get in the operating room, then directs, okay, do they get 1 pack of platelets or 2 pack of platelets in the ICU in that first hour after? Or do they get 2 of FFP and then we correct them again based upon TEG? So I think it helps us fine tune that. But to me, the critical point and the success of hemostatic resuscitation is halting the bleeding on that first go round. So that, I think, is the break point. I love TEG. I think it's the way to go. But I think if you don't fix the bleeding in the first go round, it's not going to matter how much resuscitation you do.
Well, in terms of unstable pelvic fracture management, Dr. Burlew, is there anything else we should be thinking about, or maybe any key take-home points for our new incoming fellows? Ours are just starting today, and I know Alex Schwed just graduated, and he's off to New York.
He is on his last day today before he heads to New York.
Awesome.
Yes.
Well,
I mean, it's still July, so
right.
no, he's staying until the bloody end.
Oh, that's great.
I
Well, we're
know.
so
I
happy
know.
you guys took him, and he's a fantastic surgeon. I'm sure he's an even better trauma
Yep.
surgeon for
We've,
being with you
we
guys.
we are very fortunate. We've had some terrific fellows and hopefully have added to their education. I think it's interesting. I was talking to our resident group this morning actually about pelvic fractures. So it's a it all we were talking about, and I think the key thing from my perspective for anybody is to have your algorithm,
Yeah.
to know what the resources are at your disposal, what you can comfortably do within your system, and then to have a very clear breakpoint for when you're going to institute different things. Because I think if you haven't thought through that algorithm before that unstable patient hits your trauma bay, you're not going to be able to rapidly employ the things that are going to save that patient's life. So,
Right.
this is what we have developed here. I think it is eminently translatable to any trauma center. And you have to make sure, as we talked about, that multidisciplinary approach and really having every component of that working together with clear guidelines, clear trigger points, clear intervention. What are the different parameters that push you one direction or another? And yes, there are some real life lessons learned that are the tips and tricks that sort of we relay in conversation and whatnot. But I think that overarching clear guideline and direction and everyone at the table having buy into that, that's what I think ultimately ensures success.
Thank you so much, Dr. Burlew. I know we had some technical difficulties getting
I know.
on.
Sorry about that.
Oh, not at all. I'm just super excited that we're actually able to touch base, and I'm sure that our listeners are going to take a lot away from this. And I'm really looking forward to the AAST talk. I,
It's
I have
I
a
wish
sense
that
as to where it's going to go.
I was going to say I may have shown my cards a little bit, but again, it's the fun of being an academic surgeon is the ability
Absolutely.
to innovate and come up with better ways to take care of our patients and to really try and on every single patient see if we can improve our outcomes. So no, I wish that the AAST was in person. I'm
Oh,
bummed not to
yeah.
be going to Hawaii,
Yeah,
and that
same
I'll be in
here.
my office instead giving my talk. But that's the way it goes at the moment.
Yeah.
So it's been great to talk to you. Thank you. I
Oh,
am
you
honored
too.
to have been invited, and I think this is a terrific thing. So kudos to you.
Awesome. Thanks, Dr. Burlew. We'll talk soon. Stay safe.
Sounds good. Thanks so
All right.
much.
Of course.